The debate over on-site versus remote contrast supervision is reshaping medical imaging. But what if remote was faster? A recent survey reports 30% of centers saw quicker responses. This surprising speed could be a solution to the projected shortage of 2,000 radiologists. One reason for the quickness: remote radiologists have a singular focus, free from clinical distractions. We will now break down the benefits, risks, and required systems for patient care and compliance. First, let's establish the baseline. For decades, the supervising physician had to be physically on site. The pandemic prompted a major policy shift. CMS has now made virtual supervision permanent, effective in 2026. This was a strategic move to broaden care access, particularly for rural areas without full-time radiologists. This whole discussion centers on risk. Severe reactions are rare at 0.01%, but can be life-threatening. So the rules changed to meet modern needs. But what technology and people are needed to make it safe? The first pillar is technology. It requires high-performance, real-time, two-way audio and video. This ensures immediate consultation, and platforms must be HIPAA-compliant. The second pillar is the on-site technologist. They must be trained to recognize reactions and be prepared to administer emergency medication under remote direction. But the tech is not alone. The ACR mandates a safety net. Another qualified licensed practitioner must be physically present to manage any emergency hands-on. Finally, for compliance and reimbursement, documentation is paramount. Records must detail who provided supervision, how it was done, and list any interventions. With these systems in place, what are the tangible, real-world benefits that facilities are seeing? Benefit 1. Significant cost savings by reducing the need for on-site radiologists and expensive locum tenens coverage. Benefit 2. Better manpower use. One radiologist can cover multiple sites, directly addressing the workforce shortage. Benefit 3. Greatly expanded access to care for patients, preventing long travel times and appointment cancellations. And benefit 4, as we saw earlier, 30% of centers reported faster response times due to a more focused supervising physician. The case for virtual supervision appears strong, but it comes with substantial risks and professional friction. A major concern among radiologists is the risk of commoditization. Does being off-site devalue their role and reduce reimbursement? There is also a professional identity risk. As radiology pushes for more patient visibility, does remote work send a conflicting message? But the biggest question stands. When a rare but severe reaction happens in a virtual model, is the outcome truly as safe? This exact concern is fueling professional pushback. The ASRT has proposed requiring a practitioner to be physically present, not just available. Implementation is also made more difficult by a patchwork of state-specific licensing and telemedicine laws, creating regulatory hurdles. We have clear benefits clashing with real risks and regulatory disagreement. How do we resolve this tension? When a reaction occurs, the system works in concert. The tech identifies it. The on-site practitioner provides hands-on care, and the remote radiologist directs. This highlights the core conflict. CMS policy enables virtual models to fix access issues, while the ASRT's proposal prioritizes traditional hands-on safety standards. In the same way, while virtual models address the radiologist's shortfall and cut costs, they fuel the fear that this efficiency leads to the commoditization of expertise. The choice is not between a good and bad system, but a careful balancing of trade-offs. We are trading physical certainty for greater access, efficiency, and focus. The future is likely a hybrid model. High-risk patients may always require on-site supervision, while routine scans in well-equipped facilities can be done virtually. Regardless of the model chosen, success and safety depend on 3 pillars: reliable technology, continuous staff training, and clear emergency protocols. Comparing direct and virtual supervision shows a complex picture of benefits and risks. The debate is pushing the field to redefine presence and safety in a digital age. The task for every professional now is to critically evaluate internal protocols and engage with professional bodies to help shape future patient safety standards. The evolution of supervision is happening now. Building it safely and effectively is a shared responsibility.